Okay, good evening, everyone. Welcome to the March meeting of the Health and Wellbeing Board. Councillor Josh Blacker, Cabinet Member for Healthy Lives and Chair of the Health and Wellbeing Board. Welcome to you all this evening. We have some apologies from absence. We have apologies from Councillor Mason, but we have Councillor Shaw here substituting in. We have Councillor Raz's apologies and Councillor Steed's apologies. Councillor Wall, you may know, stepped down from Cabinet at the last meeting of Council, so won't be attending. But I'm sure everyone thanks her for her contributions in her portfolio and as a member of the board. I think that's all the apologies we have, Keith.
That's it as far as I know. Yeah.
Fantastic. So we will move on. There are no urgent matters. Are there any declarations of interest anyone needs to make? No, fantastic. Then there aren't any matters to be considered in private. So we move on to the minutes of the meeting in January. Were there any comments in terms of accuracy on those minutes? No, fantastic. Then are we happy to approve those as excellent? I can see some nods from around the virtual room. Fantastic. Which takes us on to Dan and the Health Watch update.
Thank you, Chair. Because I don't have a full patient experience for the board this evening, I thought we would look a little at online consultations. So at the end of last year, we created a couple of additional questions that surrounded online consultations in GPs, and 106 people over a period of about 75 days responded to those questions. A third found the online consultation process very easy to use, and then the other 60-odd% ranged from difficult to not too bad. From there, 20% said that they overall preferred the phone rather than online consultations. So 1 out of every 5 that we talked to. 70% of the 106 people that we talked to actually had an online consultation with a GP, and 75% described that experience as positive or somewhat positive. Where we found the consternation or concern was around the process in getting an online consultation. So 50% felt like they needed to call despite filling out the application, as they felt they weren't sure whether or not the kind of everything was confirmed and the process was going forward. That falls in line with another 33% asking for reassurance that, in fact, the application or submission form had been received and that they were awaiting an online consultation. The concerns amount when we look at the submission form itself. So 100% of those we talked to felt like there were too many questions and that they were having to give too many answers online. This increased the concern with 100% of the people that we talked to wanting to know who read their answers and who read the submission forms and decided what next steps would take place in an online consultation at their GP. So from that, we offer up a single recommendation, either ideally on the website, but also in GP offices, to just explain how the consultation process is sorted, who looks at it, who decides next steps, whether it's at the bottom of the submission form or in an email to confirm that they have received the submission. Either way we think would work, but it's definitely something that probably needs to be in place so that population maybe increases their confidence and understanding and has less concerns about having an online consultation. So just a small piece for me. Happy to take any questions. But other than that, Chair, happy to end.
Great, thank you. Anna.
Thank you, Chair. Sorry, my video is not working. It was really just a comment, Daniel. I think it's really interesting hearing that feedback when we're talking about digital inclusion, that even if we put things in and they seem to work and people seem to be okay with them, actually that's an awful lot of people that are checking or not sure. And I think, and not just for health services. So it's one of the kind of inclusion aspects that we've got in health and wellbeing strategy, but it will be really interesting just to take that forward over the next year in terms of a number of actions. I think those suggestions are sensible, and I know there's groups across council and NHS working on these kind of things. But yeah, just really helpful to hear that feedback. And Daniel, if you've got anything written down, it might be useful to share it with some of the groups as well. Thanks, Chair.
Can do.
Vijay.
Yeah, I was just gonna echo what Anna said, Daniel. It's really useful and insightful what you've learned, and to be honest, I'm not surprised by some of the comments, particularly in relation to the e-consult platform that is used, and it is somewhat clunky, I would say, and there are potentially a multitude of questions that the patient needs to complete before it does get submitted. I think each practice will have their own internal process and policy about how they manage e-consults, and as a generally speaking, at a high level, they are generally screened by one of the administrators to identify those clinical e-consults compared to the administrative ones, because patients not only use it to ask or have clinical queries, they also use it for administrative purposes. For example, either requesting a repeat prescription or requesting whether a particular report or medical certificate has been completed. So there are other reasons why e-consult is used. And as you know, in Northwest London, we do have two different platforms that are used. Ealing PCNs and Ealing practices opted to continue with e-consult, whereas the other 7 boroughs in Northwest London decide to move over to patches, and we are probably due to do a sort of one year review shortly in terms of comparing the two in terms of patient experience as well as the feedback and experience from individual practices as well. E-consult have, as part of their software development, there are a number of milestones that they have been trying to look at and to develop, and one of them is an e-consult dashboard within the practice, so that they can have an easy access to what is coming in through e-consults, and then to try and sieve out what is administrative versus clinical. But that development is still being progressed, and it hasn't been rolled out as yet to its maximum potential. So I think we'll probably, I think in Ealing, I think we do need to go back to primary care and general practice when we get to that position, to get further feedback from general practice and compare that with patches to decide whether Ealing practice should continue with e-consult or move to the system that is used across the other practices in Northwest London. But I would be useful for us to perhaps have a further detailed conversation around some of the feedback that you've received, and then how we can then use that to inform general practice as well.
Great, thanks, Vijay. That's really helpful, and seeing that review might be helpful as well in terms of bringing it back to the board so we can understand how that's gone as well. But I'm sure all the GDPR policies must be in place, and if it may just be a case of making that clearer to those who are accessing the service, to give that reassurance. So thank you, Dan. Was there anything else you wanted to add?
No, thank you for the time.
No, fantastic. Anyone else have any comments or questions then? No, so I think thanks, Dan, for that update as always. And I think we move to Kerry to give an update on the learning disability strategy and action plan.
Thank you, Chair. So colleagues will recall that we've been in the process of developing the Ealing Learning Disability Commissioning Strategy across adults and children for people with learning disabilities in Ealing. This is a joint commissioning strategy. The documents attached set out the engagement programme within the commissioning strategy, significant work in terms of developing a co-production model, lots of discussions with lots of groups and people impacted through the development of the strategy. Through our discussions with the community and people with learning disabilities, we've come up with 7 priorities. The 7 priorities are meaningful lives, feeling safe and keeping safe, travel, learning, healthy lives, the transition from children to adult services, and good networks for information and communication. There's more detailed work set out in the paper in terms of the different areas of the strategy and the commissioning plan. There's overlapping work that's already in train. So for instance, we've been doing a lot of work with the Learning Disability Partnership Board and colleagues from community safety and colleagues from the voluntary sector with regard to travel and keeping safe. And we hope to bring a video to the Health and Wellbeing Board shortly with regard to safety and travel on public transport in the borough. There's a lot of work set out within the strategy, but I think this provides a good basis for the understanding of the work plan for people with learning disabilities within the borough of Ealing and how we can support them and improve their lives living in the community. There's a really strong vision statement at the start of the report that sets out the expectation for the strategy in Ealing, people with learning disabilities will be treated just like everybody else. This includes people with learning disabilities and autism, and it is only possible for people if they have the right support. I think that's a really strong message that sits at the front of the commissioning strategy. So it's really handing over the report to the board for comments and views. What we plan to do is to bring an action plan back on a regular basis to Health and Wellbeing Board to show and evidence progress, and potentially we can bring colleagues from the Learning Disability Partnership Board who will be overseeing a lot of the work through subgroups of the Partnership Board. Thank you,
Thanks,
Chair.
Kerry. This is a really good piece of work, and I think it's important just to note that it's been co-produced as well. This is not the council saying how we want things to run. This is co-produced with, as Kerry says, members of the Learning Disability Partnership Board, people with learning disabilities, providers. So, people who are experts by experience, I think was the phrase in the report. So it has been co-produced, and there's an easy read version of the strategy as well, which I think is really good to make sure it's accessible to those it will affect as well. So it's not just a dry document that sits somewhere. It's been co-produced and is accessible. So with that said, are there any comments or questions then from the board to Kerry? Neha.
Thank you, Kerry. As you know, I've seen this before, and it is a really, really good, strong strategy. I'm really keen to see how we develop the action plan. I know very clearly in here there's very clear asks under each of the priority areas that have been identified, but turning that into an action plan and being really clear about who's then going to take a lead on those various things, and sort of over what time frame as well. Is it right to just start to put that action plan together and then a first update back to the Health and Wellbeing Board, or are you thinking of putting the action plan together and bringing that to the Health and Wellbeing Board? Just wanted some clarity.
So thank you, Neha. Work has already begun on a number of these areas of work, and I think the action plan will be an iterative process. I think we'll learn and grow through the development of the plan based on people's experiences. So what I'd propose is that we bring regular updates back to the board, updating on where we're at, and to take comments and views on the direction of travel, and if there's any changes, we can use that to influence the outcomes.
Thanks, Kerry. Simon.
Yeah, two questions, Kerry, and maybe for Daniel as well. So from the acute trust perspective, one question is there anything we can do in terms of supporting access to employment? So we've got quite a successful scheme with Harrow College called Project Search, in terms of sort of apprenticeship type role into the trust, supported through the Project Search team, and Harrow College oversee it, working with our trust. But I think of the last cohort, 11 of the youngsters got permanent employment as a result of that. So that's something I'm sure we could have a look at, in terms of we need an external partner in terms of helping to facilitate an education and college side of things. But we'd be very happy to have that discussion in terms of what we can explore. And then the second comment was around, in terms of, as part of this work, have you picked up any sort of feedback in terms of experience of accessing acute hospital services, in terms of Ealing Hospital per se? And or, Daniel, is that something that you have looked at or will be looking at as part of the health, what sort of engagement and feedback from patient experience?
Thank you, Simon. In terms of the employment, I think that's a really strong offer. I think as anchor organisations, there's a lot of work that we can do across the piece for employment of young people and older people with learning disabilities. And I think that's something we could start looking more deeply into as we develop the work programme. The DWP data shows that Ealing's got high levels of employment of people with disabilities compared to the rest of London, which is strong. But I think that there's always more that we can do. We know that employment makes the biggest difference to people with learning disability in terms of their health and well-being, but also their satisfaction with life. So it's certainly something we can look to taking up with you. And we're doing some work currently with the commissioners to look at our current arrangements for employment into and remaining in employment. I think getting a job is only half the battle. It's remaining in employment is an important piece. In terms of, I haven't got any specific data on engagement with the acutes. We do a huge amount of work with colleagues from West London Trust in terms of the community team for people with learning disabilities, and we've got very strong engagement and understanding there. And I think we've spoken before about things like vaccine hesitancy and people with learning disabilities has been a big challenge. And there's been some strong work there, but it's certainly something we can look into, Simon.
And Daniel, is there anything you wanted to add on Simon's second question?
I think one of the things that comes out in our data is that they're always, the harder to reach groups see less representation. And because we tend to be in the GPs and the hospitals, while we do get to talk to everyone, some groups are better represented than others. I think if there is an opportunity to talk to larger parts of the disabled community about challenges in primary and secondary care, we would definitely jump at that. We are currently pursuing more opportunities in care homes and day centers in order to receive patient experience feedback. So, but hoping to expand beyond that.
Simon, it may also be something, I know, Kerry, I keep volunteering the partnership boards for things, but it may be something that the partnership board can discuss, because I think that's one of our stronger partnership boards at the moment, isn't it? So maybe something you can come and talk to them about.
I think you're absolutely right, Chair. I think there's a real opportunity, Simon, if there's a data gap there for Simon and Daniel to maybe speak to the power group who support the engagement through the partnership boards. There's a really strong group and engagement there.
Okay, happy to pick that up.
Definitely.
Great, thank you. Any other comments then on the strategy from anyone? Roy from SCAG, I think I had a question. Roy, if you wanted just to, there you are, just ask that, because I think partly I think has been, may have been answered, but if you ask that and Kerry can provide his response now.
Yes, indeed. Thank you, Chair. Thank you, Kerry. That has answered some of our queries. Just to say that as a group, we welcome the All Age Learning Disability Strategy Review Report and its recommendations for improvements in the support services for this group of service users, regardless of their age or their level of disability. There's always a danger that a wide-ranging strategy like this will be directed towards perhaps more of the groups that are more able, rather than the groups that are more isolated within the learning disability and autistic groupings in Ealing. But I just wanted to say that a lot more work obviously is required to put these plans into action, and we've heard a bit about that from Kerry already tonight. But the question is really, in supporting the report, are the council and all the departments within the council and the local NHS services really on board with this strategy, and they're going to help find the funding and the staffing to form these action development groups and to implement the policies. And we wanted a bit more information about the time scale. I'm welcoming the time scale of regular updates to the board, but perhaps we need more information about each of the priority areas, about when they think that more progress has been made. Thanks.
Thank you for the question, Roy. In terms of the strategy, the strategy document provides a framework for developing a dynamic work plan for achieving the strategic priorities as set out in the strategy document. As this is a significant piece of work, there'll be development of discussions in terms of what the work plan consists of, and also whether any bids for resourcing will be based around that. What I'd aim to do is to bring or to share for the next board and a draft of the work plan. We can share that with you at or before the next meeting, and then as we progress with the work plan, develop any thoughts around the resourcing required to achieve the goals.
Thanks, Kerry. I think it's also worth noting, obviously, we passed the council's budget last Wednesday, a week ago, with significant investment in both adults and children's. So, you know, that investment will filter through to delivery of services. Obviously, it's somewhat catching up with 2 years of inflation in that, and you know, still local taxpayers are being asked to bail out social care system when we need a big sustainable settlement from government, and a lot of the grants that are available are kind of ring fenced around discharge, particularly in adults. So our flexibility is somewhat limited, but we are investing in the services, so it will, as Kerry says, filter through eventually as we go through the action planning process. Okay, should we move on then? If that's noted, we can move on to our kind of slightly meatier item on the London North West NHS Trust strategy. And I wondered, Simon, before we get into that meat, whether you might just be able to give us a bit of an update on obviously the current doctor strikes and junior doctor strikes, and how the trust is coping and performing at the moment.
Yes, thank you, Chair, and thank you for the opportunity to talk about the strategy in due course. Yes, so obviously this is the third day of the junior doctors strike, and just to emphasise that when people talk about junior doctors, it is those who are in their first year out of medical school, rising up to many who've got 8+ years experience. So very many experienced sort of staff grades, etc. And specialist registrars as well as the very junior doctors fresh out of medical school. So it's a big hit in terms of the medical workforce, and probably represents somewhere in the order of about 45% of our medical workforce. So the implications are significant. What I would say is that our consultant workforce has risen to the challenge magnificently, as well as some of our advanced nurse practitioners and others who have changed their roles in the same way people change roles in response to COVID. People have had to adapt and change their roles in response to the strike action. So we've been able to maintain the services and provide 24/7 in our key areas like at the emergency departments, like critical care, like emergency surgery and cancer care. We've gone into a sort of command and control phase, and obviously the fortnight before, a lot of preparation in terms of looking at rotas, being clear in terms of what shifts needed to be covered, and organising that on a micromanagement basis. So, and we've had sort of daily sector calls as well. The reality is that so far we've coped extraordinarily well to date. We continue to be extremely busy. 1,000+ attendances across our A&E and UTC departments on Monday. And obviously we've still got to focus on the discharges as well to ensure that we keep flow going. But the consequence of being able to redeploy staff to support those emergency services, critical care and emergency surgery, etc., has been that we've had to cancel a whole series of elective procedures. So that's about 2,500 elective operations we cancelled, as well as outpatients attendances. That's a massive logistical exercise in terms of communicating with patients. And obviously we'll have to try and reschedule those in as a priority at the earliest opportunity. So we continue to focus on maintaining safe service over the next throughout this evening, but also recognizing people who have worked, there are some people who have worked 3 nights on the trot and extra shifts. So there'll be a bit of time in terms of rebalancing the workforce back to normal shift patterns. And of course, there is the risk of further industrial action going forward. So I think on the positive, we coped and kept the show on the road. And just to remind people that in previous strikes, there have been derogations where the unions have agreed that staff would still work and support in areas like A&E and emergency and critical care. That hasn't been the case this time. So Labour has been withdrawn from all those areas as part of the strike action, which is what has made it particularly difficult and challenging to cover in the way that we are. But we're no different to others. But we're proud of our staff in terms of the way that they have responded across the organisation, and many have gone the extra mile in terms of the hours they've worked and the flexibility that they have shown. And there are a number of people. So a number of you will know Miriam Harris in terms of A&E consultant at Ealing, and for example, she will have worked 3 nights in a row in terms of covering Monday, Tuesday, Wednesday. She's not alone in doing that. There are many others that have done that to keep the services safe. And just the one other thing, so that was the strike update. But just for clarity, that in terms of the UTC. Urgent Treatment Centre. I think I might have reported this previously, but just to confirm that we were asked to take on the running of the Urgent Treatment Centre at both Northwick, CMH and Ealing on the 26th of January. We've done that. So we now run the UTCs on the 3 sites. That gives us some added flexibility in terms of resilience, I think, in terms of managing the UTC and A&E pathway. And again, many thanks to the GP partners, some of whom have volunteered in the UTC or ED, and the system's transitioned smoothly. And it's been possible to improve the alignment, as I said, between UTC and ED in terms of managing demand. And we've seen significant improvement over the last couple of weeks, where we're seeing 90% performance rates in terms of treatment of patients coming through the UTC. Pause at that point, take any questions on the doctor strike and P&E, if you like.
Great, thanks, Simon. Councillor Shaw.
Yeah, thanks, Chair. I was just wondering, welcome this strategy, and it's very interesting. It's a very meaty document, obviously, but within there has been, and I know it's recognised within the document, a really sort of chronic problem with HR, recruitment and retention, and you do identify sort of, that there is a need for, filling clinical spaces, if you like. So I was just wondering, how you thought, or would you like to comment on that, and how you think that could be improved? Because I can't sort of see that within the document, although you recognise it, what can be done. I know there's a shortage right across London and the country, in fact, but, how could it be addressed?
So can I request that we hold that till we do the strategy presentation piece, because one of the key objectives is around our workforce. So hopefully we will give some sort of response to that, but I'll come back to it after we've done that, because this was just a quick update on the strike before we get into the strategy presentation. So if you don't mind, I'll come back to that at the end of the strategy presentation.
Yeah, that's no problem at all. Yeah.
Sorry, thank you.
So, Chris, you had your hand up briefly. Did you want to come in?
I was just going to echo Simon's comments and just mention, for the Community Mental Health Trust, obviously we've also had junior doctor industrial action. We had 70 or 80 trainees missing across the organisation, and have followed similar processes that Simon described to have other members of the MDT and senior doctors covering. We believe that we've had some cancelled planned care, more to the tune of 200 or 300 appointments for each of the 3 days, rather than quite the scale that's been described in the acute sector. But really grateful to all of our workforce and colleagues for their patience and support, just to add from that perspective.
Okay, thank you. And Vijay, is a similar update, I think, on the...
Yeah, so from a primary care perspective, obviously, in terms of our junior GP registrar, which is about 5% of the GP workforce in North West London. So we did the maths, and it equated to about 5,000 appointments. But again, primary care absorbed those appointments and was able to continue as business as usual. And also, as Simon says, that primary care colleagues have supported A&Es and UTC rotas over all our sites across North West London over the industrial action period.
Great, thank you, and thanks everyone for those updates. And I think kind of probably important for us to recognise that it's not your faults that we're in this situation. It's the government for not sorting out that pay deal, and you may not be able to say it on behalf of your organisations, but certainly from our perspective, we're on the side of the junior doctors, and we kind of hope that the government gets their act together and gets a proper pay deal on the table for them as soon as possible. And we recognise that means disruption to patients, but hopefully that should help force the government to do something. Simon, do you want to then with James go through the strategy presentation?
Yes.
We can then come back to Councillor Shaw's question about, I think, a relevant one on workforce and retention.
Absolutely. Entirely relevant. So thank you, and thank you for the opportunity of sharing the strategy with you here this evening. Our previous strategy was developed in 2017, and it was developed at the time when SAF actually was still around in those days. And obviously SAF has gone, lots of other things have happened in that time. We've had COVID, we've worked very differently in terms of the North West London sector, but also as acute trusts, as a collaborative. And and so that it was right and proper that we needed to undertake a review of our strategy and our vision for the organisation going forward. And I think for me, what was absolutely key was the process we went through in doing that. What we learned from COVID was the importance of our staff, the importance of our partners, and the importance of engagement with patients. So we had a real focus in doing it in a very, very different way. And we've also known that when we've had CQC investigations into or reviews in the trust, one of the first things they always ask our staff is about strategy. Do they understand it? Do they understand how their role contributes it? And therefore, you know, vitally important to make sure it was very much a bottom-up engagement process. But also, this is really important in terms of having produced the strategy, how we share it, how we socialize it, how we get our staff to support it, but also how we get our partners to support it going forward. So the process for me was very key, as well as what's there in terms of the content. So I'll pause at that point. And, you know, we were very fortunate in the organisation in terms of having James Biggin-Lamin, who's our Director of Transformation, who has previously worked in the private sector doing lots of strategy work for other organisations. So it was right and proper that we utilised his skills and experience in helping us to develop and take it forward. And with him tonight, his peers who did the guts and the grunt of the work in terms of with quite an inclusive team that we built internally. So we didn't buy in any external support. We used our staff and seconded staff to help us in doing it. Again, part of that the importance of the way that we develop the strategy. So I won't say any more. I'll hand over to James.
Thanks, Simon. Councillor Backer, can I check? We shared some slides. Is it helpful to put those on the screen and take people through those, or just talk to the papers?
I think if you could share the slides, that would be really helpful, just to keep us on track.
Join us for our class on Saturday.
And then I think someone might need to mute themselves. Roy, if you don't mind putting yourself on mute, I think, because there's a bit of background noise. But go ahead, James.
Thanks, and hopefully you can see this. I'd like to just spend a few minutes sharing the vision that we're setting out in our strategy, some of what's different from that with the strategy, in particular our link with partners, recognizing the audience and focus tonight, and then how we're going to be measuring and making progress on our strategy to help keep us on track and see some of the progress we want to make. Our vision, our strategy is to put quality at our heart, and we've shared and created this with our staff, our patients, our partners, to put that central to what we want to do. And what we recognize with our new vision, with quality at our heart, we're lucky and we're fortunate Simon shared some of the fantastic things our staff and that happen in our organizations every single day. But to really make a difference across our communities, thinking about some of the impact, the challenges we've seen, we need to be doing that not with examples, but as a consistent way of working. And so whether it's the care we provide, the employment we provide, the work we do on some of the support services that brings all this together, our partnerships, quality has got to be at the heart, the means and the end of what we're doing. Simon highlighted the extensive engagement, and it was grateful for some of the steer we had from the health and wellbeing community, health and wellbeing board in the past. For example, when we came and introduced a strategy, we were challenged around Somali translation, which we went and put and added extra comments into that. So it's grateful for the feedback as we went and shaped this along the way, and it's our most extensive in terms of engagement in creating this. So we really do feel it's been influenced and owned by our staff and our patients with the input of partners. We talk about quality in our heart, and the vision is very deliberately capitalized, because actually it's also about being the values-led organization. These are our trust values that were created by our staff through another extensive engagement exercise before the COVID pandemic and have been updated. And these have a lot of recognition and support. So we wanted that as part of that, because this vision guides our behaviors every day. And that vision, quality at our heart, goes from that consistent quality, but in everything we're doing. And from that, 4 objectives to support that. We feel if we can achieve these, they complement each other, they help that deliver that strategy, but really set out some of the priorities we want to work on. I'll introduce these and then go into a bit more about the partnership one, and then some examples of what's different with some of the rest. Our 4 objectives are around providing high quality, timely and equitable care in a sustainable way. So our primary purpose is, as a care organisation, how we go about providing that care, the experience people provide. Secondly, about being a high quality employer where all our people feel they belong, empowered to provide excellent services and grow their careers. And we hope that in recognition of being a high quality employer and the chance to retain and support and be attractive to staff addresses some of your questions, Councillor Shaw, that I'll come back to. That will base our care on high quality, responsive, seamless, non-clinical administrative services. This I'm very proud of being part of our acute strategy, because quality of care in modern healthcare is not just around the clinical laying the hands on the patient. It's a whole series of examples, the administration, the example earlier with HealthWatch with some of the administration around how you even ask for appointments. That high quality interaction and the support many of our staff to provide to that direct patient contact is central. We do that incredibly well. And then lastly, we will build high quality, trusted ways of working with local people and partners together improve the health of our communities. Recognizing that care, we're here when people are sick, but how do we promote the health outside, both of our staff and partners in primary care, mental health and community, social care and beyond, and looking at how we can help contribute towards that as an anchor organisation and through the work we do. I'll just say a little bit around bit more on the partnership opportunities. We recognise, and we had this street very strongly about the importance of those working relationships, because the challenges are our patients. They're seeing many different organisations, many different ways of influencing that. We recognise we have a responsibility as an anchor organisation, how we can, as one of the largest, if not the largest employer in the boroughs, and as one of actually a very good payer relative to other employers in the boroughs, the opportunity to create opportunities, careers, and much else. But these partnerships, how we go and support in that high quality care, whether it's patients moving between services before they come to our service, or how we support others look after the same communities we're all caring for. And some of the commitments were set out around how we think about the priorities across North West London, the work we're doing, particularly with the acute provider collaborative that I think would have been touched on at previous health and wellbeing boards, and the work we're doing with Imperial, with Chelsea and Westminster, with Hillingdon, the work that will come in time with the Cerner electronic patient record. We'll all be sharing the benefits that will bring. But actually beyond that, work around discharge, whether it's around work around mental health as people are coming into our hospital, or patients with areas like dementia where we need to work together. And our work with primary care partners, the quality referrals, because actually if we can get the right information to people straight away, it saves patient waiting. It helps support our GP colleagues and their teams provide that care and that advice very, very quickly. We've set some priorities for this year, and that in particular is some of that work in the interface. We know there are opportunities to improve and think about some of those areas as a precursor for some of the other work, as other health and wellbeing strategies. Other strategies are coming together and then supporting that to the neighbourhoods and other places. Just on the other objectives, just to give a flavour of some of what's different. First of all, on the quality of care, we've tended to use what I call the DASI formulation, high quality care for all, that goes back to 2008. We talk about care being safe, effective and patient-centered. We heard very strongly through the work of the engagement, equity, and how we think about the impact we have on different people characteristics, whether that's race, whether it's learning disabilities, where people live or age, how we think about that and the outcomes, and being much more proactive and focused on that. The timely care, recognizing particularly the impact of the COVID backlog. And around sustainable care, we need our care to be at a cost and a way of delivering that's affordable, because that creates the space to invest and improve in new services. And that's where we're really focusing on the waste, as well as the contribution with some of our services in terms of environment and our green plan that we have, and sort of contributing towards some of that. We, as an employer, have almost over 2/3 of our employees come from Black, Asian and multi-ethnic backgrounds. We recognise that diversity is very important, but we also recognise we're not doing enough, or haven't done enough in the past. If we've recently had our staff survey results, there is still much more we can do relative to others. We're committed as an anti-racist organisation and focused on how we take steps as an anti-racist organisation to support our staff. And through that, we know by looking after staff, that then supports our communities as well, in terms of the example and the leadership we provide. So we've set an explicit goal around that, as well as some other goals around how we will act and be a better employer and support our employees. We're looking at and have focused on how we don't just think about healthcare as the clinical care, but all of the support services around that. And actually frustration our clinical colleagues and other staff have day to day when the systems, the things just don't work that well. The computer says no, the support isn't there, and how we address those support services and make them much more efficient, frees up their time to be focused on what they do best, being paid and providing care for patients, and not the procurement or the HR or the finance issues. We've got other people in the team who can help along with, and how we change that relationship and support that. What this means across different communities and how we expect this to change, and why we hope you help us support and make some of these positive changes. For our patients, it's around that consistency of high quality care, wherever they've come from, whatever their needs, whenever they need that, and that will be by days of the week as well, looking at how we really target that 7-day working over time, where that makes a difference to the care we provide and the opportunities and equity between our sites. That continuity of care to help people go home sooner with the right support, and looking at areas like virtual wards to support and links up around that. Around better communication, talked about support services, and as a favoured employer, so local people will be looking to London North West and wanting to come and grow their careers with us. Councillor Shaw, your question around what will we do around employees and how do we address some of the gaps? Well, we think actually what's in our gift is by being an exceptional employer, that by empowering them, by giving the satisfaction, the focus on retention, that will help reduce the number of vacancies, that getting rid of some of the pebbles in the shoes of frustrations, that the data to help people make better decisions will encourage people to stay and grow their careers here, because the other opportunities it offers in terms of research and teaching and much else. And by addressing and being a employer who demonstrably values its employees with a health and wellbeing officer and the other support, word will get round, and it will encourage more people when they're making a choice to come and work with us. And that work with partnerships as well, with it looking at different workforce roles, how we partner with areas like Brunel, who are launching their new medical school, and other workforce roles like physician associates and much else, create these new career opportunities for people to come in to address some of the vacancies. Comes back, and this is where I hope some of the strategy is complementary, by being sustainable as well. We'll get the right people if we work out the demand and capacity and deliver our services in a sustainable, effective way. Sometimes we might have more people in a service than we need if we use the technology, the innovation, some of the transformation to make that possible, and we'll rebalance and be able to support to get people where they're needed most and address some of those workforce gaps, make the whole approach more sustainable. I'll just touch on our sites, particularly Ealing, and we set out in the strategy what it means for our different sites. Our sites have different strengths and opportunities, and we've thought about really making the most of that. Central Middlesex as an elective hub, focused on timely and efficient planned care experience with areas like the elective orthopaedic centre, ophthalmology, outpatient but not emergency medical care. Ealing Hospital, really looking to make better use of the site as the DGH central to the community, and something we as an organisation know there is so much more opportunity to use centres of excellence in areas like gynecology, or sort of a women's centre of excellence, not maternity, but sorry, the other parts of women's health, thinking about the opportunities there as centres of excellence around the A&E and the support around it to make use, to support the local community and actually the work it helps across other hospitals being at the centre, and the investments like the Community Diagnostic Hub. And then Northwick Park continuing as a major emergency hub, major centre for the specialist surgery, backed up by the support and resources of the site. So you get these different flavours and really making most of the different estates and investing in them to achieve that. Interest of time, I'm going to just skip ahead. The last thing I'm going to touch on partners, then just where how we know we're going to be making progress. Just on our partners, we hope by setting out a strategy with some clear priorities, you know what we're looking to work with and where we're really seeking opportunities to collaborate and make a difference on. So we hope some of that conversation and where we can join up helps. We hope your priorities are reflected in here, because we listen very carefully. So this is not to say what's important to our communities. We looked at the data, we heard from people. We want to support that. We also hope we can really learn and share. That's with the Acute Collaborative, but with others to make better use of that, and be much more open and promoting what's happening using that in different sorts of connections, not just health connections, but areas like education, employment, and as an anchor institution. In terms of how we'll know we're making progress, we've set out in our strategy a number of measures against each of these objectives. It's 12-ish. I say ish because some of the timely standards, we think about some of the performance standards, we didn't just want to pick one. But the idea here that across all of these objectives, we've got clear ways to get a sense of, is what we're doing making a difference? We've set aspirations to be top quartile against this. So we've benchmarked, we've looked at what good looks like, what high quality looks like, and over the course of 5 years, head towards there. And we'll update each year, so the trajectories we manage, so it's not going to be sort of a last minute squeak in, but see progress along the way. But we hope that transparency helps us, and you can challenge us if as when it's not coming through. It might be the plan's not working, how we refine that plan over 5 years and use this to steer us in the right direction. One of the areas that we'll be asking your help with is we want to actually measure, as a partner, are we a good partner? We don't go out and ask people this particularly regularly. Occasionally we do a stakeholder survey, but not that regular interaction like you would say a patient feedback survey. And so we're going to be introducing a new performance indicator where we're interacting with partners, and that's not just at the most senior level. That's, for example, working on a discharge pathway together. People have the opportunity to feedback and say, what's it like to work with us outside, and therefore what we can do to improve. And we'd like to see that ideally improve over time. So to close, invite people to help and support us. We're your local hospital. We've got here with your support, with your input. We're not going to be able to achieve this by ourselves. We're going to need a lot of help and advice and input along the way. We've set out and seen the health and wellbeing paper that the full strategy and all of the details online. You'll also see a number of videos where senior leaders, some of our staff, some of our partners are talking about what some of this means as well, and examples with staff, sort of some of that video across. So we hope that gives a bit more of a flavour on top of what I've shared today. But thank you very much for taking the time to listen, and looking forward to answering further questions.
Thanks, James. Thanks, Simon. Anything else you wanted to add, Simon, before we move to questions?
No, I think, to be fair, James gave a comprehensive and fluid overview of what's in the strategy. Clearly, there's far more detail in the document itself, but we're not going to go through that. People have got the opportunity to read that in due course. But yeah, we're proud of the strategy. We're grateful for the support in developing it, and obviously the strategy is only as good as the delivery. So it's the engagement and delivery that's key now. So we will need your help in helping to deliver it and making it a success. So happy to take any questions.
Great, thank you. I think Anna had a hand up briefly. Oh, it's back up. Anna.
I got in quick there. Thank you, Chair, and thanks, colleagues, for going through that. Really helpful, and you're right. I think there's really strong alignment, especially with the health and wellbeing strategy that's coming up at the next meeting. I think just 3 things that really struck me, which I think are really positive. I think adding in equity as part of quality, I think, is really key. And I think thinking about, like you said, how to measure that, and really, would be great to work together on that, because I think there's a lot to do across all of our partners on how we measure that and how we monitor it. And really thinking about that at different stages of people's pathways and clinical journeys, rather than just looking at kind of access or outcome, but really thinking about all those different ones. Anchor institutions as well. I think, a lot of staff will be Ealing residents, North West London residents and their families, and really thinking about that as a really major employer and for all of us as well. And then I think the last one was just that place-based work. I think really great to see that really clearly in there. Thinking of people not just as a patient at a moment in time, but really thinking about, people as part of their communities and how we can work together on that. So yeah, just a really big thank you. It's come together really well. And I think when we're doing the action planning for the health and wellbeing strategy, I can already see quite a lot of clear alignment. So hopefully you'll have a list of actions ready to go when we come and ask for them. But yeah, thank you.
I was going to say exactly that, Anna, because there is a line in the bigger document about supporting partners with their health priorities as well. So really good to see. Simon, did you want to comment on that, or do we go straight to Chris?
Welcome those comments, and absolutely, the more we can join up our strategies, clearly the better, and the stronger they'll be, and the better chance we've got of making a real difference to our citizens and our patients. So absolutely support.
Great, Chris.
Thanks. Not really a question, but just to really welcome this as a partner, and on behalf of the borough-based partnership, for the engagement that took place to develop it, and also an offer to the board that West London Trust has also been refreshing our strategy. So we'd be very happy to share with you that as well, and we look forward to working with London North West on the delivery of the 2 together.
Thanks, Chris.
Great. I mean, I was going to pick up on that equity point and the talk about being an anti-racist organisation as well, and just ask, measuring it, I think, as Anna said, will be a real challenge. So kind of some sense of how you measure progress on that journey. And if there's a sense of, do you truly understand where you are currently? Because I think that, there's feedback from staff, feedback from patients, but do you, and I think probably a question for us as well, Anna, in terms of the health and wellbeing strategy, do you understand the baseline of where you are? And then what does equitable care look like in practice? So what would the difference be? Because I think, we can tell you from our history, and you mentioned shaping a healthier future, one of the reasons we opposed changes at Ealing Hospital so much was the equity of it, the impact it would have on particularly the community in Southall who are closest, and the demographics, clearly an inequitable decision. So would that kind of thing kind of affect your decision making in future? What does it mean to the trust to say that, and what difference does it make to people's care and then to the decisions you make as a result?
Yeah. So in terms of taking the first one, in terms of being anti-racist, I think as part of the response to COVID, the equity issue in terms of the impact on people from different communities has been quite stark. But also we saw that in our workforce as well, and I think we've had quite a strong a staff-led group in terms of promoting equity in the organisation. So we do have a BAME staff network in the group that has been led by the staff side, engaging with the leadership of the trust, and has been quite challenging, I think, back to the trust in terms of where they think we're at as opposed to where we think we're at. And clearly there was a mismatch. And I think the first thing the first big step I think we're saying is that we aim to be anti-racist. It's not good enough to just say we think we treat people equally. I think it is a statement of intent to say that our ambition is to be an anti-racist organisation, which I think is something we've got to demonstrate and take steps on that journey, and working with our BAME network in terms of doing that. And that is about a whole range of different things in terms of looking at representation of the workforce across the different grades in the organisation and leadership roles. It's looking at in our recruitment processes in terms of the composition of panels. It's looking at career progression and progress. It's looking at complaints and bullying, harassment, and there's quite a high profile case in the HSJ last week from a trust that was found against in terms of discrimination. And I think there's a whole range of measures we're going to be putting in place to try and turn the dial and make a real difference internally. And then, perhaps James, you've got your hand up. Do you want to pick up the second point in terms of the chair's comments?
Yes, the second point was around the equity of care and measuring it, how we understand it today and what it might look like. So on the measuring, the honest answer is we don't have a very good way of measuring it yet, and we recognise that in the KPIs that we need to develop one. So I'll share a little bit about how we're thinking about it, and Anna, to pick up your offer, this is something we I think need to design and develop together. At the moment, a number of our metrics we could, if we chose, look at how they compare between people of different ethnicities, people of different age, people of different where they live, whether English is a second language. That's not very easy to do, though, within our data, the way we've set up our reports. It's certainly not something we're doing as standard. So the first thing to do is a sort of commitment to make that much easier. When we're having discussions and thinking about quality, challenge ourselves and say, well, this is an outcome that is 50% for everyone, but how does that vary by different characteristics and how does that influence it? In terms of measuring that and seeing is there an improvement, our idea is to think about some sort of index where if you took today as a baseline, or as we develop this, is it getting better or worse? Because we don't want to just pick one outcome and we don't want to just pick one group as difference, but almost thinking about if forgive my maths, I was a maths teacher once a time, but not really a very good one. The level of spread you might see in terms of variation across metrics, is that getting less and less over time? Because if it is, then we're providing more equitable care. We need to make sure the standard of care is rising as well, but certainly more equitable care. And that's something we need to develop almost as some clever algorithm, clever way of calculating that through our systems would be keen on. I think as part of that, that will help us understand it. But then as we're thinking about improvements and changes we're making, it will challenge us with the lines of inquiry and where we're looking for making differences and how we involve people. An example of work we've been doing recently that touches on this is around our do not attends. And we've had a rate that was higher than it should have been. It was around 12%. We've got it down to just under 10%. But it's got stuck at just sort of that 9-10%. So now we're digging in to say, well, why is it this sort of stuck there? What more can we do? And how might that vary if we're calling people where English is a second language? They're not going to be able to respond to that letter. So how do we offer that in translation? Or how do we call someone who knows the language in advance to be able to have those conversations? There were lines of inquiry we think we can improve our operational processes. There's a lot we could do to help with that. And where I hope it looks like is these inadvertent barriers that I'm someone privileged never to sort of experience because I speak English as the first language and everything else. We make sure that people who are not able to put that across are able to get the same high standard of care without these same barriers in the way, that same high experience that helps contribute to their outcome. And we'll see that go through ultimately by reducing the spread in the variation. Actually, that helps improve the quality for everybody that we'd see over time.
Brilliant. Thank you both. Councillor Shaw.
Yeah, thanks, Chair. First of all, just in terms of sort of Ealing Hospital and what's on there, obviously when I see sort of more efficient or better use of services, and I cut through the management speak, what I'm really concerned about is what will be there for residents of Ealing and what is most convenient. We've seen it in the Shaping a Healthier Future that's been referred to before, where there was thoughts and proposals to downgrade it, and downgrade services away from Ealing, so taking things away from residents in Ealing. So I was just wondering, sort of what does that mean in practical terms? Can you guarantee us that there's a good hospital with full services there? Obviously, the A&E is on there, which I appreciate and I welcome. So that's great. But then also just in terms of community diagnosis and whether we call them hubs or whatever, obviously this is more practical for people, and within there, it would be welcome to have these, but there's not much detail around how that might look and how that might take services away from other centralised points, whether that's hospitals or whether that's growing GP services and GP hubs type thing. So I'll just, could you give us some comments and a bit more detail on that, please?
So in terms of Ealing Hospital, there's no intention to take anything away from Ealing in terms of services. So what we're looking to do, so Ealing, I think, over the last few years has been an underutilised site and resource. We're looking to address that in terms of the balance of services there. So we have invested. So we have reported here that we have invested on the site in terms of things like the cath lab, in terms of endoscopy, refurbishments. One of the things that is big schemes on the site at the moment is the community diagnostic centre. That is going in the old maternity block at the moment. That's due to complete the back half of this financial year into the early part of the next. So the back end of this year, early part of next year. So that's an addition on the site. There will still be the traditional sort of diagnostics there to support the acute pathway, but the community diagnostic centre, given that's in the maternity unit, will have a separate sort of entrance and exit and that kind of stuff, and it'll provide additional capacity and resilience on the Ealing site. and we will continue to look at ways of improving services there. So James alluded to perhaps in terms of women's services and gynecology and gynecology surgery on that site. That's one of the services that we are looking at in terms of perhaps strengthening on the Ealing site, and certainly in terms of gastrosurgery over the last sort of 18 months, we've increased the volume of that on the site. So going forward, Ealing is a very much a critical part of the acute offer from London Northwest, and we absolutely do recognise that we need to have the balance of services right between Northwick and Ealing and CMH. You will probably be aware that in terms of the elective orthopaedic centre, that's been out for public consultation, recently went through the JOSC, and the plan is across Northwest London that more elective orthopaedics surgery will go to a centre of excellence that will be on the CMH site going forward. But for London Northwest, a lot of that activity already happens at CMH. James, I don't know if there's anything else I missed that you wanted to add.
I'd expand a tiny bit on the Community Diagnostic Centre just to explain its context. This is part of actually a national programme of investments, of which Ealing Hospital is one of the sites in Northwest London. The background to this is recognition that as a NHS, we have fewer MRIs, fewer CTs, fewer diagnostics than other comparable health systems. And this will help complement the work GPs do, where instead of it being bottlenecked into too few spaces, actually it's going to expand access, help earlier cancer areas like cancer diagnosis, where the NHS lags other comparable health systems. And we hope that investment, and there's opportunity there with it being right at the heart of Ealing's community, thinking about some of the partnership with GP and other pathways and some of those links with hospitals. And as Simon's touched on, this idea of centre of excellence, that we're wanting quality at our heart. There are some services like A&E. To have A&E running effectively, you need a number of other things behind it that will need to work effectively. And for them to be sustainable, they need to be at a critical mass and a critical volume, which is why we want to do more at Ealing site. And linked to that, this idea of centre of excellence, we've set this up where examples like the elective orthopaedic centre, you get specialists, or as you know, a specialist build, a specialist setup. It might mean some people some of the time have to travel ever so slightly further, but this is occasions where you might need to have that for a one-time episodic rather than going again and again. And the benefits are faster access, faster treatment, much more productive. It manages the sustainability of the workforce and the career opportunities around that consolidation together. But those core services people need regularly, or is where we're sort of making sure they're protected and supported in local hospital or in Ealing Hospital.
Great, thanks both. Chris, I think I saw your hand go up briefly again, but disappeared.
Sorry, the conversation moved on, but I was merely going to think a bit more about the equity point that had been raised, and the collective thinking that we might do in Ealing through the place-based partnership around this. I know that we've been doing it, Nana and others, around the response for health to the commission in the borough, and certainly around some of the metrics where we've, as a mental health provider, West London Trusts has a number of requirements looking at equity and equality issues within our patient groups, and we're very happy to share learning, particularly around, for us, it's around the demography of individuals accessing our services, people on waiting lists, people who receive restrictive practices within our mental health model. For instance, we know that in some of our areas, individuals from African and Caribbean backgrounds are more likely to be picked up by the police or arrested on Section 136, and actions that we're taking to address this. And of course, in our workforce, we all in the NHS have to use the and report on the indicators around workplace race equality, which is a fairly standard position that we're trying to monitor improvement on across the organisations. And I think we've been discussing in the place-based partnership, including with Ealing Hospital colleagues, how we can compare notes as we seek to improve our performance on those metrics. But really, really welcome it and keen to be part of the conversation and share and steal from each other in terms of the learning collectively.
Thank you, Chris. I'd welcome that. We've done very well with things like the workforce waste equality standard on the employment side, but actually thinking about equity as a measure of care is where there's real opportunity to improve. Thanks.
Anna, did you want to add on the?
Yeah, I keep using the phrase health and wellbeing strategy, and you're going to hear it a lot coming up. But I think just on that point, Chris, totally agree. And I think that's something, and I know we've got to just finalise the strategy and take it here in May. But I think that's something that's come out really strongly when we've been talking to partners, is really with the kind of equalities, diversity, inclusion work, which is everything you've just mentioned there, colleagues, trying more proactively to share together. Whether that's sharing learning, whether it's sharing resources, sharing training, sharing feedback from staff. You know, if we add all our organisations together in Ealing, and then also at that North West London level, there's real power in that and really good collective resources. So I think that's just a real good theme for us to kind of keep in mind as we go through, and where we are all doing this work, actually trying to do it as much as we can together. Thanks.
Thanks. And I think you mentioned the tribunal that so the first tribunal following on from the Race Equality Commissioning is taking place in a few weeks, and the first session is on health. So I don't know if others have been invited, but I'm sure it will be an interesting watch to see where we are in terms of progress and what issues are coming up. But Simon, James, Piers, thank you very much. Oh, and Neha, sorry, just before I was going to move on.
So sorry, that is literally on that Race Equality Commission first panel. We've got representation. VJ is going to join from a primary care perspective as a borough medical director, and we've got somebody from West London Trust, and I'd be really keen if somebody from London North West would join us on that. I can send you the details afterwards, Simon, but I think it would be really great.
Yeah. If you send us the details, we'll make sure we get someone to attend and be part of that. Very happy to do that. Yeah.
Great, thank you. So Simon, James, Piers, thank you again. And I suppose we'll get updates on the implications of the strategy as it develops and gets implemented in the next few years. But I think clearly the board is very much kind of on board with certainly the equity points, and kind of look forward to seeing how that develops. And I think from the council side and the political side, certainly, very much welcome, Simon, your commitment to Ealing Hospital, as I think we've mentioned before, but it is kind of very good to hear that, you know, it is I should have written it down, but no intention to downgrade any services. But there is a recording, helpfully. So thank you very much. I think we need to move to Neha then for the primary care contract. Neha.
Thank you very much. Just as an introduction before I share some slides, this is we're really pleased that we're able to start this and continue the investment we've had in primary care for quite a few years in Ealing now under the Ealing standard. Basically, this is the next iteration of that. We've had COVID in the middle of launching Ealing standard. We've had to extend the contract to a certain degree for a number of years because of the investment going into primary care, and the primary care having to then focus on vaccinations and all of the other things. And now they're all catching up, and just like the rest of the health system, trying to make sure that we're reaching pre-COVID levels of care. And access, as everybody knows, has been a real issue, but general practice has been delivering more appointments and access than it was pre-COVID. So it's been really interesting trying to support general practice through this really difficult time. And this investment that is continuing for the next 5 years through this contract will help give that security to general practice, that they can continue to retain the workforce that they would have put in place as a result of the initial investment in the Ealing standard. So that's one of the reasons why it's such a good scheme. So I'm just going to give a few more details. I'm just share my screen, just bear with me. I'm hoping you can see slides.
Yeah,
Great.
we can see the slideshow version, so it's a bit not necessarily the right screen, but carry on.
Okay, thank you. If anything is out of or you can't see, just let me know and I'll try and shift things around a bit more. So what we wanted to bring here was a high level update of what the new contract is going to include. It doesn't include all of the actual specifications being given out to primary care, partly because there are some final tweaks expected following discussions with our local medical committee, the LMC. So we're expecting that to be completed shortly, and I'm happy to then send around a version of the full suite of specifications. But in addition, once we had released this just a few days ago, there was a communication from National about the new GP contract being launched from April. I know that there are some questions on that and how that links to this, and we'll come on to answering those in a bit. So the National contract covers core general practice, but what we commission through this is some enhanced services that aren't covered anywhere else in the National contracts, either through the primary care network enhanced service done nationally or through the core GP contract. So this is that third level of contract that sits with all of general practice across North West London. So the point of this, there's three aims. There's that consistent and equitable access to primary care across the whole of North West London. So taking some of the learning we've had in various boroughs, including Ealing, and trying to do that consistently across North West London. And I know I've been asked that question in this committee in the past as well about how we're sharing that learning. So it's great news. Increase the transformation and the collaborative approaches and enabling the collaborative working across practices in a network of practices working together. And this is in particular to help with the resilience of some of the practices that may not have maybe a small practice and may not have as much workforce as a larger practice down the road, but we wouldn't want one practice to be patients receiving a suite of services and the other patients, just because they're registered in another practice, receiving a different suite of services. So what we're trying to do is create and enable these collaboratives and networks to work together so every patient gets access to all the suite of services. And as I said before, it's about investment across the whole of North West London and all the boroughs, and make sure that our investment that we've had continues, and increase investment in historical underfunded areas across North West London as well. So in order to do this, what we have done is created the contract, which rather than held at individual practice level, it is held at a primary care network. That doesn't mean the individual practices aren't delivering the services. So the point of delivery may be the individual practices, but the contract is held as a PCN, a primary care network. So they work much more closely together, and the contract enables them to do that and share some of the responsibility of ensuring that population health delivery. Over time, we're hoping that this level of contracting at a primary care network will enable a greater transformation of primary care, and as I said, about that resilience and working across the system. And as I've said before, that continuous levelling up across the boroughs. And when we became an ICB, one of the commitments was to level up some of those boroughs where the investment was low. Some of you will remember that before we started the Ealing standard, we had one of the lowest investments of enhanced monies from National into primary care in Ealing compared to all of the boroughs across North West London. And through the Ealing standard and additional monies that came, we're now quite leveled up, and we're quite well funded in primary care in Ealing, and we want to maintain that level of investment going forward, whilst levelling up some of the other boroughs who were in the position that we were in 5 years ago, or maybe longer than that. It's 2017. So this is a continuation of some of that conversation. And we started with the out of hospital services and then moved to the Ealing standard. The way this contract works is there are two components of it. And I'm just going to go to the next services, next slide. So there are a suite of North West London core services. These are commissioned consistently across the whole of North West London. They're the same specifications, they're costed in exactly the same way. We'll be measuring exactly the same across the whole of North West London. The additional funding that we have at local level, and as I said, this is an evolution, will turn into Ealing Standard 2.0, almost like a continuation. So we will have capitated specifications. So that's funding to general practice, not on individual activities delivered, but for the population. So that this is the idea is that all patients will be able to access all of these services, if not in their own practice, in a practice close by. So that's the column on the right, and there you will recognize a lot of them in the Ealing standard that we've had up until now. There are a couple of additional ones for this year, recognising some of the partnership working we've been doing recently, one on domestic violence, another on chronic kidney disease, that's what CKD stands for. And we're doing a lot more work on high intensity users and proactive care planning. And obviously with children and young people, we've had a lot of learning over the last few years on different specifications. And then on that same theme of equity, we've also got additional services that are activity-based, commissioned only at an Ealing Borough level, because we've got the funding to do that, around insulin initiation in general practice for people that need that. Pediatric phlebotomy, again, we've got a few providers delivering that in the community in GP practices, and homelessness as well. Whereas the column on the left-hand side, the North West London core services, are all activity-based, but they are consistent across the whole of North West London. And we've had all of those in our Ealing standard up until now. So for us, it's not much of a change in terms of services. In fact, we've got a couple of extra ones, having been through this journey for quite a few years, but the rest is consistent. So there's no reduction in services for primary care. And as I've said, there's some detail in the slides that have been shared, which I won't go through at this point, but I'm happy to take any questions on that at this point.
Great, thanks, Neha. Questions from members of the board at all? Don't see any. So Neha, you did mention there were some questions as well. We have had 3 questions. I don't think James is on the call, just around how the NHS revisions to the GP contract affects this, timescale, and then patient engagement. If you could quickly cover those, and then we'll make sure we attach the answers to the papers as well, so that they're available.
Sure. So the first question was around in what ways will the North West London contract be amended to reflect the guidance that I mentioned earlier, the new national contract guidance that came out on the 6th of March. So what we do know, obviously we had developed our specifications before this communication came out. So it's a really important question, because what we will have to do is go back, once the more detail comes out from national, go back and confirm that we're not paying for the same thing twice through what we're commissioning, and then make sure that everything is aligned and fair, and make sure there's no duplication of funding. The second question, and once we've done that, we'll make sure that the final version then gets sent around to this committee and gets on our website as well. The second question was the timescale for the implementation of the contract, especially those provisions that are different from or additional to the provisions of the former Ealing Primary Care contract. As I've said, actually the specifications are almost a continuation of most of our Ealing standard contracts, and if they're not, they are an enhancement of what we've already been doing. So there's nothing being stopped from what we're commissioning at the moment. The contract is being put in place from 1st of April, but we've got a 3-month mobilisation period to allow the primary care networks to be able to hold the contract. And there's a lot of work that's happening in the background at each of the primary care networks to be clear about how they're going to hold that contract. And for us, as I said, it's more of a continuation. So that's a really positive step forward, and we'll be able to continue to see that change over time. And then the part 3 was what patient, given the importance of this contract, the patient engagement, what are the arrangements being made to inform the GP patient practice participation groups of the content of the specifications, and has an information pack been developed to share with GP practice, to share with their practice population groups? And this is a really important question. As I said, there's not really that much of a change. It's actually an enhancement of what we're already doing, but it's really important that we are clear with our local residents as to what is included in this specification, and that is definitely a piece of work we need to take forward over the coming weeks as the final specifications are launched, and we'll commit to putting something together for our PPG groups.
Great, thank you, Neha. If there's nothing else on that, then we can move on to the last substantive item, which is Anna and the Health and Wellbeing Board work programme.
Yeah, thank you, Chair. We've got quite a busy May and quite a busy July coming up. I think the main ones for the May are, we've got a health and wellbeing strategy finally, so really excited to be bringing that to the next meeting, and also our autism action plan from Kerry's team, and then we've got a number of I suppose slightly smaller brief discussion, slightly for info. So we've got the council's undertaken a new annual health of the borough report, and also looking at a profile, kind of almost like a mini GSNA across each of our 7 towns as well. So hopefully bringing those to the next board. We've got the Better Care Fund update as well, which is one of our statutory functions. Health Watch reports from Daniel, and then just a fit info item for the next one, which we might bring later on in much more detail. There's a chance, an opportunity to bid for £5 million funding in terms of health determinants research. So this is really growing our research capacity within local areas, growing the evidence base about the wider determinants of health. So we're getting in a submission for an expression of interest on the 18th of April. But if we move to the next stage, we'll pull in a lot more of our colleagues here on that. So it's something we can bring an update at that next meeting. I think that's all. I have to go through July if that's helpful, but they're the main ones for May. Thanks.
Great. Thanks, Anna. It is going to be a busy meeting, but it's an important one, I think, the next one, as we agree the strategy for the next 5 years. So thank you very much. Any questions for Anna on the work programme? No. Fantastic. Which takes to the final item is just any other questions from members of the public. And I know Roy had submitted one on the living wage. Roy, I don't know if you wanted to come in with that.
Yes, thank you, Chair. Yeah, obviously everybody probably knows that Ealing Council has agreed to pay domiciliary care workers across the public, private and voluntary sectors the real London living wage, the real stroke London living wage, which is £11.95 per hour. Still fairly low compared to other jobs in health and social care. Certainly will be quite a bit below any settlement that there is in the NHS for healthcare assistance. So we'll be watching out as to whether the differentials increase. But we are broadly welcoming the increase to the real living wage. But there have been some niggles and some feedback from the workforce, from domiciliary carers and from personal assistants, that they're paid the London living wage in Ealing, but their work often takes them to across borough boundaries, and they're not clear whether they're going to get the real living wage, the London living wage, when they work there. So I was just wondering whether we know what the neighbouring boroughs pay for domiciliary care per hour, and whether we can find out, and also if it does look as though some boroughs are not paying that, whether we can use any of the joint bodies that Ealing is part of to persuade other boroughs to commit to this higher hourly rate for domiciliary carers. Thanks.
Thanks, Roy. And glad you welcome it. I mean, it was a £2 million a year commitment that we made on that to give that uplift. And I think, Kerry, I'm right in saying we've got over 1,900 care workers who've received an uplift this year. There will be more in May as we move to the 11.95 rate. And I think, having talked about equity, I think it's really important to note that obviously we know the care workforce is, I mean, I think 83% women in Ealing, predominantly Black, Asian, and other minority ethnic backgrounds. So it's not just a point about paying more money, it's paying more money to groups who have been paid less money than other groups in the past. So it's a point about health, income inequality, as well as providing kind of not only the deserved rate of pay, but a better experience for those who are receipt of care. I think working with North West London is going to be really important, because obviously we've done domiciliary quite easily. Well, it looks very easy on the surface. I know Kerry and the team have done huge amounts of work in it in the background and made it look very easy. As we look to expand that to care home workers, obviously those packages are funded not just by us, so they're funded by other boroughs as well, but they're being delivered in Ealing care homes. And we want to make sure those care homes are paying the living wage as well. We're not going to do that without getting, as you say, Roy, all of North West London on board, and that kind of those authorities that pay Ealing care staff to look after their residents in our borough. So we will continue the work we're doing across North West London to support that and to persuade them to do it. I don't know, Kerry, if we know what other authorities do pay at the moment, but I know from other conversations about different contracts, different authorities are in different places.
Yeah, there's a wide variation, Chair, as you would assume, across the 8 boroughs of North West London in terms of the rates that they pay their care staff. I think, as you've covered very ably, the importance of doing this in Ealing is going to support us have a more stable care market going forward, is impacting on the health and well-being. I think it was something like 58% of the people that are benefiting from the increase for the real living wage work in Ealing and live in Ealing. So we're making a difference to the communities that we serve in Ealing. It's difficult for me to comment as an officer, Roy, in terms of how we influence other boroughs. I'm expansive, but I'm not that expansive to want to move into the other areas of North West London and influence their contracting arrangements. But it certainly is, as the Chair has said, this is something we'll be looking in a great deal more detail in terms of the care home settings. As you can imagine, many of our care homes were a net importer of people from other boroughs into Ealing care homes, and therefore paying the real living wage becomes more of a complex issue, but it's certainly something we'll be looking at.
Great, thanks, Kerry. Chris,
Thanks.
hopefully you're going to say what I think you're going to say and give us some good news.
Yeah, there's good news, I think, from the NHS side, which so West London Trust, I think, is now an accredited living wage employer, and that I think is a principle that's being replicated by a number of the other NHS providers across North West London. I think we've all committed to work in that direction. This applies to our own staff, and I think it's required some adjustments to those on the lowest bands within the Agenda for Change pay scale. But obviously it also starts to apply in order to retain the accreditation to all of the contracts that we let. And certainly within West London Trust, that for us, our biggest subcontractor is our estates facilities cleaning and catering supplier, and they are already, the trust has moved them onto a living wage as part of that. So I think there is a similar direction of travel on the health side that might be welcomed.
Brilliant, thanks, Chris. And I think it comes back to the point I think Simon was making earlier about our role as anchor institutions, and the effect not only we can have as direct employers, but as you say, in the supply chain. And as Kerry says, so many of the people who work in our borough live in our borough as well. So it's that investment that kind of inward into the borough. Simon.
Yeah, just to make the point that in terms of our own staff, we do comply and pay the London living wage. In terms of our contracted out services, we are in the process of reviewing all of those and have a commitment that we will move to making sure that the London living wage is paid as part of those contracts going forward.
Brilliant, thank you very much. So that brings us to the end of the agenda. Thank you all very much for coming, and particularly to those James and Piers and others who aren't formal members of the board, but thank you for attending and giving us your updates. And we will see you next on the 10th of May.